Coming to the factors affecting fetal oxygenation, so uteroplacental is very, very important because this is linking between the maternal and the fetus. If anything is affected, so it could compromise both of them. Now coming to the induction and augmentation of the labor. So when are you going to do that one? BIS Hope score is important. As for their cervical characteristics, what are those 5 characteristics that you will calculate in the induction of labor? That's what they can ask in the CDM, where you have to write down, and in the MCQs where you have to choose from the options. Position, consistency, effacement, dilation, and the station of the fetal head. So you need to do these ones. Now, induction is indicated when the risk of the continuing the pregnancy exceed the risk of associated with the induced labor and the delivery. Induction and augmentation. Induction is when you are going to start artificial initiation. Augmentation when it's already started. Now you are just helping it to go smoothly. Consider the following before induction. What are those ones? As we said, discuss this one. Contraindications, indication of the induction, gestational age, cervical favorability, fetal presentation, potential for the OPD, fetal well-being or fetal heart rate, and membrane status. So these are the things that you need to consider before doing the induction. And what are the cervical characteristics? This is cervical and this one is overall. So that's why you need to remember both of them. So kindly do remember both of them because they can be asked in the CDM where you have to write it down as it is. Now, indications. Indication is late term postpartum pregnancy, most common reason for the induction, because if this is increased, this can lead towards the fetal death. So 31 to 41 weeks, you are going to do the and the maternal age is more than 40. So you are going to start with the induction of labor. More than 41 week, you are going to do the offer the induction of labor if the vaginal delivery is not contraindicated. But if it's contraindicated, then you go for the cesarean delivery. But if it's more than 41 week, expectant management elected, like depends on the fetal surveillance, if the fetus is alive or not. If its fetal is alive and the fetal movement can be counted by the mother, then BPP every 3 to 4 days. And according to that, you can offer the vaginal delivery or maybe cesarean delivery, depending on the fetal surveillance, if the fetal is okay. And not just the fetal surveillance, but depending on the mother choice. That's more important than anything else. Okay. Then coming to the maternal factors, diabetes mellitus, second most common risk factor for the induction, gestational hypertension, more than 38-week gestational age, preeclampsia, more than 37-week gestational age. So in these conditions, you are going to do the induction of labor. Other complications is renal, lung, chronic hypertension, cholestasis, and significant but stable antepartum hemorrhage. Labor induction may be offered to patients age more than 40 at 13, more than 39 weeks. So in those conditions, you are going to induce a labor right away due to the increased risk of stillbirth. Maternal fetal factors, isoimmunization from or chorionitis. Fetal factors are basically the suspected fetal jeopardy is suspected, macrosomia or fetal demise, IUGR, oligo, or these conditions, then previous stillbirth can be cause of the where you can need to do the induction of labor. Coming to the risk factors, failure to achieve the labor or the vaginal birth, tachystole with the fetal compromise due to fetal rupture. So that's why to do it right away. So maternal side effects through the medication or uterine atony could be one of the risk factors. What happens is contraindication in those conditions where the delivery is very unlikely, maybe carcinoma, herpes, or structure deformities, or the uterine rupture. So in those conditions, you are not going to do the induction of labor. What happens is you might spread the infection to the fetus as well. So fetal maternal is basically placenta previa or vasa previa, because in those conditions, we usually go for cesarean delivery. Cord compression, cord presentation, in usually in those conditions, we also go for the cesarean delivery. Fetal distress and the. So what are those methods? Just a second. So what are those methods? The methods are basically cervical ripening, use of the medications or other everyone can hear me, right? Okay. Use of the medications and other methods. So cervical ripening is one of the most most used one in the induction of the labor. And what are those ones? Like the methods: intravaginal prostaglandin, intravaginal PGE2, intracervical PGE2, intravaginal PGE1. And the most easy one, which is very commonly used, is Foley's catheter placement to mechanically dilate the cervix. So depending on those ones, what patient demands or what patient wants, you can choose either of these ones. Then coming to the induction of the labor, this is the important one, amniotomy. Usually the question asked is which one you prefer. Is amniotomy better or oxytocin better? In Canada QBank, I think they asked this question. So over there, they have given the option of amniotomy and oxytocin, both of them in the separate choices, right? So the answer was amniotomy. But uh, oxytocin could be used because it's non-invasive. But depending on the scenario, if the patient is having a certain type of choice, if she wants amniotomy and if she wants to deliver right away, she does not want to wait, then all of these choices. So, but we prefer amniotomy over oxytocin by if you go by bookish knowledge. So coming to the artificial rupture of membrane to stimulate the prostaglandin synthesis and secretion, may try this as an initial measures of if the cervix is open or soft. Then amniotomy plus IV oxytocin, more women delivered vaginally at 24 weeks. So if they have given you option of oxytocin separately, amniotomy separately, and there is a choice of amniotomy plus IV oxytocin, then you have to choose amniotomy plus IV oxytocin. But in Canada QBank, they have given all of these options separately. So that's why. Then amniotomy alone. So if you are using just amniotomy, amniotomy plus IV oxytocin is preferred over this one and had a fewer instrumental vaginal deliveries. Coming to oxytocin, 10 unit in a 1 liter normal saline run to 0.5 to 2 MU per minute, IV increasing by 1 to 2 MU per minute every 22 6 seconds. So you don't need to remember. Just remember the oxytocin. Reduce the rate of unsuccessful vaginal deliveries. And current recommendation is use the minimum dose to achieve the active labor. Okay. So the potential complications, what is that? It can lead toward the tachysystole, muscle fatigue, vasopressin, leading to the antidiuresis. So it can lead toward the PPH. So that's why the complication is more in the oxytocin than amniotomy. That's why amniotomy is preferred, because oxytocin can lead toward the PPH. Augmentation of the labor with amniotomy or oxytocin may be used to promote the stronger and the more frequent contractions. Now coming to the dystocia of the labor, what happened is basically the management is important, because other than that, the 4 P's of the dystocia: power, passenger, passage, and psyche. So bleeding causes power. Contraindications, contractions is hypotonia and all of these things, but the most important is power. Power is basically leading towards maybe too much power is not there, maybe mother is already tired, so these kind of things. Then passenger, if the baby is more bigger than CPD and having the passage like CPD problem and maternal soft tissue tumor or any herpes infection. Psyche, like hormone problems. Then starting with the management, confirm the diagnosis of the labor, like you are going to do that, this is labor, right? Then after that, ruling out the CPD, concern for the dystocia, and then management. If CPD ruled out, IV oxytocin augmentation plus the amniotomy, optimize fetal movement, and then do the optimized pain control, do the delivery. Risk of the dystocia may be maternal distress, maternal infection, PPH, and then fetal compromise, uterine rupture, and hypertension. Now coming to the shoulder dystocia. Same thing, the presentation like turtleneck, they can give you the picture of ultrasound where they're showing the turtleneck and asking you if you can find out what is this. This is basically the diagnosis of shoulder dystocia. What is the goal? To displace the shoulder, anterior shoulder from the anterior symphysis and follow a stepwise approach to the maneuver. So you are going to do the clearotomy or the Zen Valley maneuver or symphysiotomy. Usually this is done by obstetrician. So you just need to know if you can make the diagnosis and the complications. What are the complications? Hypoxic ischemic encephalopathy is one of the important. Brachial plexus injury. What are those ones? Erb's palsy or the Klumpy's palsy. Then coming to the fracture and death. And in the female, there is an injury or PPH and then rupture. Now the approach to the management of the shoulder. Just read this one. Ask for help, starting with the ask for help. Then legs in the full flexion, anterior shoulder disimpaction. Then release the posterior shoulder, manual corkscrew. And then a physiotomy, roll over, and then Mac Roberts position maneuver. So now coming to the umbilical cord prolapse. This is one of the most important topic of the obstetrics, because cord prolapse is one of very like 1 in 100. So a lot of people, face this one. So prematurity, pre-rupture of membrane, and fetal malpresentation, low length placenta, polyhydramnios, multiple gestation, CPD could be the cause of it. Visible or palpable cord fetal heart rate changes. Then treatment is basically emergency cesarean delivery right away. If not fully dilated, then vaginal, if and vaginal delivery is not done, then oxygen to the mother. Because in this condition, why is it important? Because in this condition, mother is also compromised. So that's why saving the mother is your priority. Oxygen to the mother, monitor the fetal heart, monitor the fetal heart rate, elevate the pressure at the presenting part of the body by elevating the fetal head with the pelvic exam. Then coming to the fetal cord warm, keep the fetal cord warm because the cord is outside, so it's already maybe dried and cold. So that's why you have to keep it warm and moist so that the blood supply is adequate. Applying with the normal saline soaks, and then roll the mother onto the all four lateral position so it's easy for them to move the fetus. And if the fetal demise is too premature, allow the labor and the delivery right away. Coming to the uterine rupture, this is also one of the most important topic of the obstetrics. What are those presentation? Prolonged fetal bradycardia, acute or onset of the constant nor lower abdominal pain, hypertonia, uterine contraction, abnormal progress of the labor, vaginal bleeding, and then hemorrhage, loss of station, maternal tachycardia. Uterine scarring is risk factors, stimulation, trauma, multiparity, and then malpresentation, and then eccrita. Rule out the abruption and then go for the rupture. Maternal stabilization is important because in this one, we are also going to save the mother. Then thromboembolism, cardiac event, suicide, sepsis. These are the most important ones, especially the suicide one. A lot of female go with a lot of big trauma, so that's why they go think of doing suicide. Pulmonary fluid embolism, it's not that important because amniotic fluid embolism is not that important because pulmonary embolism is more important. But this can lead you toward to know that if this mother has already just delivered and having the experiencing the same symptoms as pulmonary embolism, and we're experiencing the same symptom, and this is amniotic fluid embolism. So one of the things is basically in this condition, they actually misconcepted with the septic shock because they have this sepsis kind of condition going on. Suddenly on the onset of the respiratory distress, collapse, and then coagulopathy. So seizures is one of the most important that can present with the amniotic fluid. So I have seen one of the question in Canada Quebec where they were saying that she is experiencing seizure. Must be management in ICU, sportive measures, and coagulopathy correction. So that's why you need to do. Then coming to the chorioamnitis, as we already did the GBS. So the same thing here, it's an infection caused by those infection organisms. So that's why it can lead toward the preterm labor. That's one of the thing. And maybe the infection can be delivered towards the fetus as well. So low parity, rupture of membrane, and long labor, vaginal exam during labor, internal monitoring. So these things, but bacterial vaginosis is one of the most things that can cause it. And the treatment is basically ampicillin, antipyretics, and proper labor progression is important. Not an indication for the immediate delivery or cesarean delivery. So it means you are not going to do the cesarean delivery. Remember, in obstetrics, one of the most important thing you need to remember is when are you going to do the cesarean delivery and when it's it's important or it's the only choice you have. When you do it, that's different, but the only choice, that's different. Okay. Bacteremia and other fetus wound infection can happen, and sepsis, and then complication. Meconium, as she had the baby already aspirate the meconium, so call for the respiratory therapy neonatal and then monitor the fetal heart rate. That's important. Particulate meconium is associated with the lowest Apgar score because they have a meconium aspiration can lead towards the death. Then you can skip this one. Perineal acceleration, mostly episiotomy, and the third degree episiotomy is more important as here. The third degree and the fourth degree, because after that the anal sphincter is also ruptured, so that's why you have to do that. And after third and fourth, you are going to give the prophylactic dose of antibiotics. That's what the important. Recommend the postpartum pelvic physiotherapy and endoanal ultrasound to make sure that the anal sphincter is normal and it comes back in 3 to 4 post repair, 4 months post repair. Coming to cesarean delivery, you can just read this one, all the complications, just the surgery complications. Coming to the postpartum hemorrhage, Same thing, tone, tissue, trauma, and then thrombus. So 4 T's, these ones, more than 1000 ml of the blood is leaked after cesarean delivery, more than 500 ml of the blood. So most common cause of postpartum hemorrhage, avoid with the active management of the third degree of the labor. So oxytocin management, sorry, administration, uterine massage. As I said, uterine massage, because oxytocin management, definitely we are going to give that oxytocin, but uterine massage is something you don't have to give from outside. All you need to do is hand movement, right? So uterine management massage is something you can do right away. Oxytocin administration, you can do it after that. Okay. So avoid with active management. What are those active management? If they ask for one of the things you can do right away is uterine massage. Then if they ask for the three options, definitely you are going to write down the oxytocin administration, umbilical cord traction, and then uterine massage. So if they ask for one of the uh, most reliable one, that's oxytocin. But if they ask for one of the common one or one of the easy one or one of the thing that you can do right away is the uterine massage. Then uterine umbilical cord traction for the delivery of the placenta. Now more due to over distended uterus, polyhydramnios, so that's why uterine muscle exhaustion, uterine distortion, intraamniotic infection, and then bladder distension. These are the things that can lead towards the uterine atony. Then tissue, retained placenta, because if the mother is already delivered the baby and the placenta is already delivered, but you did not make sure that the placenta is already out, that can also lead towards the postpartum hemorrhage. So laceration, episiotomy can also, because trauma is one of the things. Coagulopathy, if the mother is having von Willebrand disease or any of the hemophilia factors, so that can also lead towards the thing. Here, the side things, differential diagnosis of the late postpartum is retained products of the placenta, endometritis, and sudden evolution of the uterus. So these are all of the things. Now coming to the investigation, what are you going to do? You are going to check the degree of the loss, because degree of the blood loss, because it can lead towards the shock. So shock is the clinical examination. You are going to find out, explore uterus and the lower genital tract to find out if there is any injury to the tissue or any retained products. Must be helpful to observe the red top tube of the blood. So usually it's not indicated, but if we are going to check for the coagulation profile, then definitely we're going to do that. Starting with the ABCs, because this is an emergency condition and it's an emergency case. Even if you are sitting in a clinic, if you are sitting in an emergency setting, you are still going to start with the ABC. In the clinic, you are going to send that patient right away to the emergency. In the emergency, you are going to start with ABC. Call for help to IV bore, fluid crystalloid, CBC, treat underlying cause, and the Foley's catheter to empty bladder and the monitor urine output, because she is in shock. That's why urine output monitoring is more important. Coming to the medical therapy, oxytocin, you are going to give carbetocin, you give methyl ergonovine, maleate can be give carboprostate, misoprostol, and tranexamic acid. So starting with the tranexamic acid, because that's you can give right away. Oxytocin you can give right away, is preferred in the low risk vaginal deliveries. Oxytocin IV transfusion is preferred. Now, carbetocin is a long acting. If you want something to be used for a prolonged period, then you can use this one. For the vaginal deliveries within one risk factor for the PPH. If there is one risk factor for the PPH, you can give carbetocin. Methyl ergonovine, if there is a contraindication to to the oxytocin and carbetocin, then you can go for methyl ergonovine, but we don't give it in the HTN. So they can ask for the contraindication of methyl ergonovine maleate. Carboprost is usually contraindicated in these of the conditions: cardiovascular, pulmonary, asthma, renal, and hepatic function. But it's prostaglandin, so it's kind of easy to get. Misoprostol can be used, but it has side effects of pyrexia. So most preferred one is oxytocin. Most long, if somebody is asking for long acting one, carbetocin, and for the specifically for the bleeding, tranexamic acid. Okay. So based on what they have asking in the scenario, the choice will be different. Local control for the atony, bimanual massage, as I said. Local control is the thing you can do right away. Bimanual massage, you tried packing, Beckery balloon, and then manual removal. So bimanual massage, you can do it right away, along with putting the uterine packing and then giving the oxytocin if you have to choose three options. Then surgical is basically dilatation and curettage, but these options will come after ABC. Please don't mix it, okay? Dilatation and curettage, embolization, laparotomy, and then hysterectomy. as you can see from here. Then retained products of the placenta. Obviously, if there is any uterus, you are going to explore the uterus. If there is any placenta present, then you are going to remove it manually, since you are going to see if the cervix is already closed or not. Based on that, you are going to do that. Okay. So 2 large bores IV line, then type, and then screen. And then rogam is one of the important. Don't miss rogam, because if this is a retained product of placenta or postpartum hemorrhage, in those conditions she might need more rogam than the usual one she's already getting. Okay. Then oxytocin you are going to give in the umbilical cord, so to stop the bleeding. Then manual removal of above fails, you are going to put your hand and then remove it, dilatation and curettage, and then sphazolene. Uterine inversion, if this is already been moved out. Usually we don't get these kind of cases because we are going to be tested on the family physician level. So you can just skip this one. This is just an ABC condition. Just for emergency purpose, if this comes in emergency, you are going to start with ABC, crystalloid, tocolytics, and call for help. Postpartum pyrexia. Now the patient is experiencing fever more than 38 degrees Celsius. Endometritis could be one of the cause, wound infection, mastitis, UTI, atelectasis, pneumonia, DVT. You are going to start with the history and physical examination. Endometritis by doing the blood and genital cultures, and then serum lactic acid for the early detection of the sepsis. So for the sepsis, we do serum lactic acid. What are the most common cause of the postpartum pyrexias? 5 Ws and 1 B. In the breast, engorgement and the mastitis especially happen when the mother is breastfeeding, or if she doesn't choose to do breastfeeding, because the already milk production started, so that's why. Milk, wind, atelectasis, pneumonia, UTI, episiotomy, CD site infection, DVT, thrombophlebitis, and then endometritis. Coming to the treatment, you are going to start with the infection, endometritis, mastitis. Depending on the diagnosis, the treatment will be different. We are usually going to start with the empirical broad spectrum antibiotics. After confirming the diagnosis, you can narrow it up. So empiric antibiotics suggest when the sensitivity available. Endometritis, chlamydia, gentamicin, mastitis, you are going to give the cloxacillin and cephalexin. So just remember this one. They can ask you in the MCQs by giving you the scenario of mastitis and asking you what are the antibiotics you are going to give. So wound infection, cephalexin, and frequent sits baths important. DVT, anticoagulants, and the prophylaxis against the post-cesarean delivery endometritis. Endometritis is inflammation of the endometrium. So treatment is going to be give the oral antibiotics. And if it's very severe, then you are going to hospitalize and give the IV antibiotics. Mastitis, definition of the mammary gland and rule out the inflammatory carcinoma is indicated. So lactation and then non-lactation mastitis. In the lactation mastitis, what are you going to do is basically if there is abscess, as we already see, if there's a fluctuant mass, you are going to remove it. If it's not, then you are going to do the treatment like heat packaging, nursing, and antibiotics. If this is a non-lactational one, but with abscess, in the abscess, we do the incision and drainage. And in the non-lactation one, we are going to do along with incision and drainage and then antibiotics. Why? Because in the non-lactation, the fluid, the milk is already been accumulated at one place. That's why he's having a discharge. So in those conditions, you are going to do that. So in lactation, it's unilateral tenderness and erythema. But in non-lactational one, it's subareolar pain because the fluid or the milk is accumulated over there. That's why. May have subareolar mass, discharge, and the nipple inversion. So it can be mixed with carcinoma. Some people think that this is a nipple inversion, so maybe he's having Pearls orange or something like that. So don't mix that. Broad spectrum antibiotic and incision and drainage, total duct excision. Please go and see the picture. How does they look like? That's more important than knowing their clinical factors. Then if the mass does not involve fine needle aspiration to exclude the cancer, as I said, nipple inversion, so we are going to remove the rule out the cancer. Ultrasound to assess the presence of abscess. Treatment, you are going to give the antibiotics, then may develop the mammary duct fistula. Minority of the non-lactational abscess may occur. Now, postpartum blues and depression, these are important as well. 40 to 80% to new mothers manifested by the mood liability, depressed affect, and these are the things that can happen. All you have to do is reassurance. It can resolve by the 2 weeks. Postpartum depression, if there is a suicidal thoughts, then you have to admit that person. Otherwise, all you can do is basically give the antidepressant, ask them to change the environment, and antidepressant, psychotherapy, sportive therapy, and electrocompulsive therapy if refractory. Coming to the psychosis, usually it starts within the first 2 weeks but can last for the month. So psychiatric emergency can be because they can try to kill the baby, so that's why they might need to get the emergency or maybe separated from the baby. Typically requires hospitalization, stabilizer, and antipsychotic. Then postpartum care, just give it a read. It's just important, as in maybe they can ask you, what are you going to do? Physiological changes of the postpartum, not that. Okay. Breastfeeding and the drugs, you can see, just remember the contraindicated ones. So all of those complicated ones like chloramphenicol, cyclophosphamide, sulfonamides, nitrofurantoin, tetracycline, lithium, bromocriptine, antineoplastic, and psychotropics ones. These ones are contraindicated when the breastfeeding. So that's it about the obstetrics. We mostly try to cover obstetrics and gynecology, all of it, but that's not the case for every other topics. We will just